Hello and welcome everyone. Today we'll be discussing an important topic in management of sepsis, that is whether we should treat the fever or not. Fever is a common feature of sepsis and septic shock. Most scientific societies define fever as a temperature above 38.2 degrees centigrade, but this is a lot of variation based on what should be the actual threshold. The causes, especially in sepsis, can be infectious, which is the most common, and you can have non-infectious causes as well, where the patient has a tumor, ischemia, or allergic reaction. So fever is a defense mechanism, and many bacteria struggle to survive at higher temperatures. So however, this high fever can also cause organ damage and organ failure. So the clinical dilemma is whether we should allow that fever and get its beneficial effect, or we should treat it and prevent the organ damage. Some patients benefit from fever while others get complications due to the high temperatures. So this is the dilemma that we face. So how is the body temperature controlled? We have the afferent systems which transmit the temperature changes through skin receptors, and they send it to the center, that is the hypothalamus, which processes the temperature information. And based on the processing that happens in the hypothalamus, the efferent signals are sent whether to decrease or increase the temperature based on various mechanisms, like shivering will increase the body temperature, sweating will decrease the body temperature. Like that, the hypothalamus controls the thermostat of the body. So there is a difference between hyperthermia and fever. Fever is something which is essentially internal, which is a response to the infection or immune response. Hyperthermia is more because of excessive heat production, or if the patient has exposure to the heat. So in fever, the mechanism is that the set point, that the thermostat, is turned off. But in hypothalamus, even though the thermostat is normal, the body is unable to maintain it. So the response to antipyretics like paracetamol is there in fever, but in hyperthermia you will not find any response to antipyretics. So the fever has some cellular and immune effects which are beneficial, like it reduces the bacterial growth, enhances the antibiotic efficacy, boosts the innate immunity, improves the neutrophils survival, enhances netosis, and better T cell function is seen. So these are the beneficial effects that we get when we have fever. But it does have some side effects, like it can cause direct cell death, it can worsen this organ failure which is there because of the sepsis, it can cause hypotension because of the vasodilatation, increased clotting, it triggers clot, the excessive heat causes clot formation. So it does have some side effects as well. So it is the balance and the net effect on the individual that needs to be assessed. Now there is an important role of the gut microbiota in the fever. So how does it impact is that the gut microbiota may explain why fever patterns vary among septic patients. In general, what we know is septic patient must be having a high temperature, but that's not really the usual fact. So ICU patients were grouped based on fever trajectory, that is the temperature patterns, and in this it was found that the gut bacterial compensation at ICU admission was seen. Specific bacteria were linked to different fever responses in sepsis. The mouse experiments have confirmed these findings. So what were those key findings? The lacnospiria was found in patients who had lower fever. It was also found in lungs of critically ill patients and linked to worse outcomes. Regarding COVID-19 patients, fever was associated with altered gut microbiota, including increased enterococcus, Saccharomyces, and in neutropenic fever, that is fever in patients with low WBC count, depleted gut microbiota may worsen the neutropenic fever by loss of protective metabolites, and the Archimacea bacteria may thin the gut mucosal layer, making the gut lining more vulnerable to infection. So how does this interaction really impact? The relationship is bidirectional. The body adapts to help the gut bacteria survive during the infection, studies in mouse have shown that after injection of toxins that induce a sepsis, intestinal cell, they release a sugar, that is a fucose. The gut bacteria consume this fucose to maintain their population. Now, this adaptation was linked to better infection tolerance. So, the link is bidirectional. The body is trying to preserve its microbiota, and the microbiota is also trying to save the body from the invasion of the foreign bacteria. So, the clinical impact is that this bacterial microbiota has a fever response in sepsis because it regulates the fever and the inflammation. So outcomes have been seen in terms of bacterial balance and mortality. So the interventions like probiotics, microbiota targeted therapies, restoring protective gut microbiota have been some potential interventions in the management of sepsis, though we don't really have any positive results as of now. So apart from sepsis and infection, there can be other causes where the temperature can rise. So we must keep in mind of those things while trying to treat any fever in the ICU. Say for example, the patient can have heat stroke. This is a neurological dysfunction, and in this the increased heat results in organ dysfunction, renal failure, respiratory alkalosis, and other complications. Malignant hypothermia, here the muscle activity is increased, resulting in increased temperature generation. So there is a rapid temperature increase, muscle rigidity, and a metabolic crisis. You can also find high temperatures in patients who have brain injuries like bleeds, post cardiac arrest, where the temperature management can be off role. So in septic patients, we have seen that the patients can have different type of responses to temperature. For example, if the patient is normothermic, then they have a slight higher mortality compared to patients who have actually a temperature. However, if you see the patient who are hypothermic, they definitely have the double of mortality than patients who are having fever. So fever definitely does have a clear protective effect, and patients who are hypothermic have a significantly increased mortality. Now, if you look at the trajectory, in the trajectory, as we have already seen, normothermia and hypothermia, they have a clear relationship, hypothermia having more worse mortality. But if you look at the temperature resolution, that is a rapid resolution of the hypothermia, is associated with extremely good mortality risk compared to slow resolution. But overall, hypothermia is better, but if the temperature is going down quick, then it has got a good mortality. But definitely, if the patient is hypothermic, the mortality is skyrocketing. So should we control fever in sepsis? Fever control in sepsis varies across the ICUs, with only 22% of the ICUs following a strict protocol for temperature management. Now, common practice that we have is fever is usually targeted in neurological patients, acute coronary syndrome, and in patients who have severe sepsis or with established organ dysfunction. Liver failure patients are often left untreated. The key consideration that we should have is that no strong evidence suggests that high temperature, high fever increase results in mortality with sepsis. However, targeted temperature management may help by reducing the metabolic demand, increasing the blood vessel tone, and infection control with antibiotics, though still remains the first priority. So now the thing is, this is a very individualized thing. We need to understand whether the patient is actually getting harmed or still has some benefit of the fever. We still don't have any clear-cut markers as of now. So how do we control the fever in sepsis? The commonest one that we use is acetaminophen or paracetamol. It lowers the hypothalamic set point. Exactly how it is done is not really understood, but it does results in reduction of temperature. In high doses, it can cause liver damage, so it must be kept in mind. The evidence that we get is around 700 septic patients on the HEAT trial, where it did not reduce the ICU stay or mortality, and the patient with fever with short duration and temperature difference was minimal between the groups. So clinical usage is that it is a common safe option for mild fever reduction. However, if the patient is hypothermic, it can be used. Whether it is to be used at a temperature less than 39.5 is something which we still don't know. Now, apart from that, you have the NSAIDs, which act by prostaglandin E2 and they reduce the fever. The major risk they have is the GI bleed, the renal and liver damage, and they can worsen the infection by suppressing the immune response. We have a lot of clinical trials on this. They have lowered the fever but did not improve the survival nor the shock. Clinical usage is they are currently not really recommended until and unless you are having severe temperatures and that is 39.5 and more, and your patient is not responding to acetaminophen. External cooling is something which we more commonly do because it has lesser side effects. Here we use the ice packs and circulating blankets, even endovascular cooling devices also we have. The drawback is that it can trigger shivering, which increases the oxygen demand, tachycardia and discomfort. Shivering is controlled using sedation and neuromuscular blockade. The key study is by the Strojan et al., where the external cooling did not reduce the vasopressor requirement but lowered the 14-day mortality. However, no mortality benefit seen at 30 days. The clinical usage is to be used with caution in extreme hypothermia, that is more than 39.5, and avoid shivering if possible. And regarding when to treat and when not to treat, there are some arguments against the fever control. That is, high fever is linked with better survival, as we have already seen. Studies have shown that preventing fever does not prevent organ dysfunction. In mechanically ventilated patients, fever control did not improve the blood pressure or the lung function. However, at extreme temperatures, the survival benefit disappears. The meta-analysis finding of 1,500 patients, the antipyretic did not reduce 28-day mortality. Arguments for fever control: non-septic patients, fever is harmful and needs control. Sepsis guidelines do not provide specific recommendations, and some studies suggest very high fever may still require treatment. So, as of now, this is the summary that you can use. For normothermia, 36 to 38, you don't really need any temperature management. For 38 to 39.5, again, no real evidence to treat this. Monitor closely and see if you are finding any features of organ failure. 39.5 and more, paracetamol first, external cooling next. Uncontrolled shivering during the cooling, do use sedation and neuromuscular blockade. For hypothermia, gradual rearming to avoid low pressure blood pressures. This is something which is still not yet proven and is a theoretical concept as of now. So the conclusion is fever is a natural defense mechanism, but extreme temperatures, if high and low, can be harmful. No strong evidence to treat it aggressively. Hypothermia is more dangerous than fever and it should be addressed. But temperature more than 39.5, use paracetamol with external cooling cautiously. Rewarming hypothermia patient is an emerging area of research. Thank you for your patience.